All right, welcome back. Today, we're playing medical detective. We're diving into a really fascinating case, the case of the uncontrollable blood pressure. Now stick with me here, because we're going to explore a pretty powerful idea.
What if your high blood pressure wasn't actually a life sentence, but a solvable case? You know, for so many people, it feels like this lifelong battle. But what if I told you that for a whole bunch of folks, maybe even up to 1 in 10 people with hypertension, the real cause is something else entirely, something hidden, something that's often missed, and get this, something that's frequently curable. That's the mystery we're cracking today. All right, so Section 1, a hypertension mystery. This is where the case really opens up. See, the mystery begins when high blood pressure, or hypertension, it refuses to play by the rules. We're talking about blood pressure that stays stubbornly high even when you're on a bunch of different medications. Or it shows up super early in life, like before you're even 30. Or maybe it just spikes out of nowhere, dramatically. These are the first breadcrumbs, the first clues that tell us, hey, maybe we're not dealing with the usual suspect here. And that brings us to the two faces of hypertension. On one side, you've got what's called essential hypertension. This is the one most people know about. It's super common. We often don't know the exact cause, and the goal is to manage it, not really cure it. But then there's the other side of the coin, our hidden culprit, endocrine hypertension. And this is a whole different ballgame. It's caused by a specific hormone imbalance, and because we can pinpoint the cause, it's often treatable and, you heard that right, totally curable.
So, what exactly is it? Well, think of it like this. Endocrine hypertension is basically high blood pressure that happens when your body's hormone-producing glands go a little rogue. You have these specific hormones that are supposed to be carefully regulating stuff like your blood volume and your sodium levels. But when they're out of whack, either way too much or not enough, your whole system gets thrown off and your blood pressure just skyrockets. Okay, so if hormones are the culprits, then it's time to meet the endocrine suspects. Let's get our lineup ready. There are a few key players that can really mess with the system, and we're going to profile the top 3 most wanted.
First up in our lineup, suspect number 1, primary hyperaldosteronism. The hormone at the scene of the crime? Aldosterone. And its MO is pretty straightforward. It basically bullies your kidneys into holding on to sodium and water. When you hang on to more water, the total volume of blood in your vessels goes up, and boom, your blood pressure rises. And here's a key piece of evidence. It also makes your body kick out potassium. Remember that clue, because it's going to be important later.
All right, suspect number 2 is a lot more theatrical. This is pheochromocytoma. It's a rare tumor that just dumps massive amounts of adrenaline, catecholamines, into your system. To really get its MO, picture tiny little switches all over your heart and blood vessels. You've got alpha switches that squeeze your blood vessels tight and beta switches that make your heart pound faster and harder. Well, this tumor unleashes a tidal wave of hormones that flips every single one of those switches to the on position, causing these insane, sudden spikes in blood pressure called hypertensive crises. And rounding out our top 3 is suspect number 3, Cushing's syndrome. The hormone here is cortisol, the stress hormone. And cortisol, well, it's a real master of disguise. It's got multiple kind of sneaky ways to drive up blood pressure. It can mimic our first suspect, aldosterone, and make you hold on to salt and water. It can make your blood vessels extra sensitive to adrenaline. It even messes with things like insulin resistance. It's a complex character, for sure, attacking from all different angles.
So, we've got our lineup of suspects. Now, like any good detective, we need to know what clues to look for. Let's talk about the telltale signs and symptoms they leave behind. Okay, so check out this table. Each one of our suspects leaves a pretty unique calling card. Remember primary hyperaldosteronism? Its key clue is often low potassium in the blood, which can show up as muscle cramps or weakness. Then you've got pheochromocytoma. Its signature move is what's called paroxysmal hypertension, those sudden spikes, along with the classic triad, pounding headache, drenching sweats, and a racing heart. And with Cushing's syndrome, the clues can be very visual. Things like central obesity, weight gain around the middle, a rounded face, and even distinct purple stretch marks on the skin. Every condition leaves its own trail of evidence.
All right, so you've got your clues. Now you need a playbook for the actual investigation. In medicine, that means knowing exactly when to start digging deeper and what tests to run to finally unmask the real culprit.
Now, you don't start this kind of investigation on just anyone with high blood pressure. It's really triggered by specific red flags. We've touched on some of these already, right? Hypertension that's resistant to multiple drugs, or starts before you're 30, or has those sudden, dramatic episodes. But a couple of other huge ones are finding low potassium on a routine blood test, or, and this happens more than you'd think,
finding a little mass on an adrenal gland totally by accident, when someone gets a CT scan for a completely different reason.
So this is where we get into the lab work, the biochemical toolkit. We have a specific test for each suspect. To catch aldosteronism, you look at the aldosterone to renin ratio. For a pheochromocytoma, you're not looking for the adrenaline itself, but its breakdown products called metanephrins. And for Cushing's, there are special tests like the dexamethasone suppression test. The point is, it's not guesswork. We have precise tools to finger the right culprit.
And this is where it all comes together. Once you've unmasked the culprit, you don't just throw a generic treatment at it. No way. You get to use a highly specific, targeted takedown for that exact cause. Let's take aldosteronism. The treatment here involves drugs that block aldosterone from doing its job. Think of it like this. Aldosterone is a key that fits into a receptor, or a lock, on your kidney cells. Medications like spironolone and eplerenone basically jam that lock so the aldosterone key can't get in. The result? Your body stops holding on to so much salt and water, and your blood pressure comes down. Eplerenone is just a bit more selective, which means it can have fewer side effects, especially for men. Okay, but now let's go back to our most dramatic suspect, the pheochromocytoma. Treating this is a really high-stakes game, especially right before surgery to take out the tumor. There's a critical, non-negotiable sequence you have to follow. If you get it wrong, you can trigger a catastrophic hypertensive crisis.
So here's the protocol, and the order is everything. Block alpha, then beta. Step 1, you give an alpha blocker. This relaxes all those constricted blood vessels, which lowers the overall resistance and brings the blood pressure down. Step 2, and only after step 1 is done, do you give a beta blocker. This safely gets the fast heart rate under control without causing a pressure spike. And this quote right here explains exactly why this sequence is so critical. It says, if a beta blocker is given first, unopposed alpha-adrenergic vasoconstriction, hypertensive crisis. Let me break that down. If you block the beta receptors first, you slow down the heart. But you've left all those alpha receptors on the blood vessels wide open and unopposed, so the adrenaline can still clamp them down like a vice. You've basically taken away the heart's ability to pump against that massive pressure, and it can cause a complete disaster. So you have to remember, alpha first, then beta, always.
So, we've gone through the mystery, the suspects, the clues, and the takedown. And that brings us to the final and honestly the best part of this whole story. Case closed. Because here is the big, game-changing takeaway. Unlike most forms of high blood pressure, the target in endocrine hypertension is often a physical thing that can be removed. Finding the source is so important because these hormone imbalances can cause serious damage over time. But the amazing thing is, the problem isn't some vague, system-wide issue. It's often a single, identifiable source, and you can go in and take it out.
And this is what leads to a cure. A surgeon can perform an adrenalectomy to take out a tumor making too much aldosterone, and just like that, the problem can be gone. They can surgically resect a pheochromocytoma, and the adrenaline surges stop. They can perform surgery for Cushing's. The hypertension can literally be reversed. We're not talking about managing a condition for life. We're talking about a resolution, a cure. Case closed.
So we end right where we started, with a question. Is your high blood pressure a solvable case? Now, obviously, this isn't medical advice, but hopefully it's made you a little more curious. If any of these clues sound familiar, maybe the next step is just having an informed conversation with your doctor. It could be the very first step in your own investigation. Thanks for joining me on this one.